Hi everyone, this is Dr. Oliver. In this PowerPoint, we are just going to discuss a few common renal disorders that you may see in primary care. The first one we're going to talk about is an acute renal failure. I also want to include in this the acute kidney injury, which a lot of the times can precede the acute renal failure. The goal, especially when you're seeing a patient in the outpatient arena, is that that acute kidney injury you want to treat as quickly as possible. So you want to find the source and correct it so that they do not progress into an acute renal failure. So an acute kidney failure is the rapid, so typically it's less than 2 days, and it's loss of the kidney's ability to remove waste and help balance fluids and electrolytes. There's lots of symptoms that you may see, and I will tell you they will vary from patient to patient. It really depends. Some patients are more resilient. Patients that have more comorbidities are ones that sometimes it'll take even less than 2 days. I mean, it really could happen if the cause is like dehydration and they're, say they're out watching their grandchild's baseball game or something. I mean, these patients, it can really happen in a matter of a couple of hours, and then they'll end up in our ER. So, but typically you'll see they'll complain of this metallic taste in their mouth. A lot of the times other people around them will notice that they might be a little bit more confused or a little bit more of a somber type mood. They might complain of a decreased appetite or decreased sensation in general. So they can complain of some tingling or numbness in their hands and feet. A lot of the times their movements are slow and they're just very tired. Sometimes they can have some flank pain. We'll notice their blood pressure will be elevated because their body's trying to compensate. A lot of them will complain that they might be nauseous or vomiting. Worst case scenario, they could have seizures or they could develop some shortness of breath. A lot of the times they can develop some swelling, although typically we may not see this right in the first couple of hours, but over the course of 24 to 48 hours, we'll notice that they're starting to swell. They also will have some urination changes, so they typically will not have much urine output. This is a nice little picture I wanted to include. So when you're talking about acute renal failure or an acute kidney injury, like I said, you want to find the source and you want to correct it. So is it a pre-renal source? Is it an intrarenal source or a post-renal? So pre-renal is before the kidneys, okay? So this could be maybe a drop in blood pressure, maybe maybe your old lady patient maybe took double of her blood pressure medication, causing a drop in her blood pressure. This would interrupt the blood flow to the kidneys. And so this would be a pre-renal cause of maybe an acute kidney injury or an acute renal failure if not corrected quickly. And intrarenal, think of that more so inside the kidneys, and this is more of like a direct damage to the kidneys. So think of some of your inflammatory disorders. A lot of people that do any type of drug. I had a 19-year-old actually it was like I think it was maybe a year or two ago, maybe a couple years now. He went on an overnight binge of meth and heroin and completely fried his kidneys. And you could actually see a huge difference on the CT scan. I mean, his kidneys were just they were just shrunk and shriveled on the CT scan. I mean, they really did not resemble much of a kidney. And this is all caused from the drugs. And so it caused that intrarenal, acute, and permanent renal failure. Post-renal, usually that's due to an obstruction, so the urine cannot flow correctly. You'll see this in a lot of older gentlemen because they might have an enlarged prostate. You can see this in women because of frequent UTIs or kidney stones. Less frequently you see it like a bladder tumor or maybe an injury from an accident or something. But basically you want to think of past the kidneys, so an obstruction of some sort. If you look down in the notes section too, I also included some different diagnoses that might cause kidney damage. So I go into just a little bit more detail there for you. So now we're going to talk about diagnosis and treatment of acute renal failure. So if you have a patient that is in more of an acute kidney injury and you're seeing them in the outpatient realm, if they have maybe more of a mild to a moderate form of acute kidney injury, and so you're not necessarily concerned that they're falling into the realm of acute renal failure where their GFR is now below 30, or they've had more than a 20% drop in their GFR. And overall, maybe they're fairly healthy. You were able to easily identify the problem of the acute kidney injury. So say, let's go back to that dehydration because that's pretty common. So, you identified that it was related to a dehydration, and you also trust them to follow your treatment plan that you're telling them. This is a person that could be treated on an outpatient basis. Now, you're going to want to see them the next day, or at the very minimum, maybe a couple of days, and you want to encourage fluids, and you want to make sure that you're following up with their lab work. But typically, people with an acute kidney injury that you are really afraid of going into a total acute renal failure, these people need to be hospitalized. Once they get to the hospital, typically hospital staff will do a kidney ultrasound or a renal CT scan, and that's because we want to see the structure. So we're trying to identify what is the cause of this event. They'll also have a complete metabolic panel. We want to look at their creatinine, their GFR. We want to look at their electrolytes. They'll have a CBC as an infection related. We can do a urinalysis. We can do the urine electrolytes. These are all important tests to be done. If we're considering an autoimmune cause, we could also do a SED rate and a CRP, although I will say it's not as common, or at least where I'm practicing at, it's not as common to see more of an autoimmune cause. Now, one thing that we do see that's pretty common is more of an infectious process. And if you're considering that, then you may want to also consider ordering a lactic acid level or blood cultures. And these are, blood cultures are things that you can order out in the outpatient world as well too, if need be. Then once the cause is found, the ultimate goal of treatment is to help the kidneys work again correctly. So we want to try to get them as closely as possible back to their baseline, and that's important. You want to go back and document what is their baseline creatinine, what is their baseline BUN, what's their baseline GFR. You want to make sure you document that in your notes so that you know what goal you're trying to reach. And we want to try to prevent fluid and waste from building up in the body while the patient heals. And then, like I said, a lot of the times these patients will be treated in the hospital. If it's more of a moderate to severe type AKI or acute renal failure, they typically will be treated with fluids if they appear hypovolemic. If they appear hypervolemic and they have too much fluid, then we will diurese them if need be. We also want to do strict INO. A lot of these patients will automatically get Foley catheters, so we can monitor that more closely. And then a lot of the times we keep them on a telemonitor too, because they're more prone to having a cardiac event as well. So just keep those things in mind. Next, we'll talk about acute pyelonephritis. This is one thing that you'll probably see on your certification exam. They really like to test people on pyelonephritis. So just make sure you understand that pyelonephritis is an infection that commonly begins in the bladder. So it starts out as a UTI, but it'll move upstream to one or both of the kidneys. Typically, you'll see it in one. If it's in both kidneys, more than likely they've probably been dealing with this for a little while, or at least a couple of days, and it's traveled it to the other kidney. So people that have pyelonephritis in both kidneys tend to have to get hospitalized with IV antibiotics, and they are in a little bit more fragile state. So symptoms of pyelonephritis, it varies depending on the age of the patient. So most patients will complain of infectious type symptoms. So, people will talk about maybe a fever. Typically it's above 101.5. A lot of the times they'll have painful urination. They'll have flank pain. They might have some chills. They might have some muscle cramping. Any of those things that could go along with a UTI as well, they can have. Although with pyelonephritis, I'll say their symptoms usually are a little bit more severe than what you would see with a UTI. I'm sure you guys know by now I love pictures. So this is a CT scan, and if you look here where the arrows are pointing, it's pointing there at the right renal lower pole, and if you can see, there's just no differentiation there in that kidney. So if you see how much bigger that is, and this is more so because this is a chronic pyelonephritis. So this is a person that gets pyelonephritis pretty frequently, and so you're going to see those chronic changes in that kidney, there. So when you're collecting your objective data with pyelonephritis, like I said, typically they're going to have a fever greater than 100.4 or 100.5. A lot of the times they'll have CVA tenderness on one or both kidneys. The UA will show typically a large amount of leukocytes. They'll have blood in their urine. You'll see a high level of white blood cells. Typically, if it's a good pyelonephritis, it's going to be over 100. To diagnose a UTI, the white blood cell level should at least be over 10. And then they're going to have protein in their urine too. You definitely want to make sure you get a urine culture, and it's going to show a significant amount of bacteria, so greater than 10,000. And then the CBC will also show typically a white blood cell count, unless they're immunocompromised, but it'll typically show a white blood cell count greater than 11,000. And then you could also see a possible left shift there, so presence of bands. And we'll go over that more in our lab module. So treatment for pyelonephritis, this solely depends on if you are treating them on an outpatient basis versus an inpatient. So inpatient, the gold standard is Rocephin or ceftriaxone IV, and typically we will give them 2 grams every 24 hours. Usually if they are hospitalized, we end up keeping them for at least 24 hours, more than likely 48, so they'll get 2 doses. And then depending on if they have any allergies or if they don't tolerate a certain medication, we will put them either on Cipro PO or a Levaquin PO. So those are typically gold standard for outpatient. So if you have a patient that you don't have to hospitalize and you're treating them for pyelo, then you want to start them on those 2 medications. And a lot of the times these people have to be on longer time frames for these antibiotics. So it's not uncommon to see them on Cipro or Levaquin for 7 to 14 days. So keep that in mind. Yes, you can use Bactrim DS. A lot of people will ask this. However, a lot of the bacteria that cause pyelo they're just not sensitive to Bactrim, and that's widely due to our overuse of it. A lot of people tolerate Bactrim, and so in the past it was used quite frequently, but now what we're finding is a lot of the bacteria just are not sensitive to it anymore, so keep that in mind. You want to make sure too, if you have a patient that's pregnant or if you have a child that comes in or maybe an elderly patient, definitely patients that are diabetic or immune compromised, you need to refer them either to the hospital or a urologist. If this is more of a frequent event, then they definitely need to be in contact with the urologist. If you have a patient that you're suspecting to be in sepsis or multi-organ dysfunction, they need to be hospitalized. The last condition that we're going to talk about is the dreaded kidney stone. If you have had one of these or if you have taken care of a patient, you know that these patients are in pain. And a lot of the times they want something right now. And, a lot of the times, unfortunately, we have to tell them that we have to wait and see if they will pee it out on their own, or so we'll give them fluids. We'll try to manage their pain as best we can. So a lot of the times this is very frustrating for patients, but we want to try to see if they'll pass it on their own, so that we don't have to do any sort of intervention, but sometimes we do have to. So kidney stones are solid masses made of crystals, and they can be made from multiple different kinds of substances, and I included those types there. So calcium, uric acid, the struvite, and the cysteine. The cysteine is it's very much less common than any of the others. The calcium oxalate tends to be the most common, and I included in the notes section here different high oxalate foods. So like potato chips, peanuts, chocolate, spinach, beets, those things, if people are eating them in high amounts, they can actually make a person more prone to calcium type kidney stones. So that's a patient education tip that we need to pass on to them. Uric acid kidney stones typically are more common in men rather than women, although they can occur in women as well. They also tend to occur in people with gout or those going through chemotherapy. So keep that in mind if you have a cancer patient. They may, while they're going through treatment, may develop a kidney stone. And then also a diet rich in purines can increase the urine's acidic level, and this is what causes that uric acid kidney stone. So people that eat a lot of fish or shellfish or meats, they are more prone to these type of kidney stones. A struvite kidney stone is mostly common in women that have frequent UTIs. And these stones, one thing to make sure that we make note of is that they can typically be very large, larger than some of the other stones typically, and then they can cause a lot of urinary obstructions. So just keep that in mind. And then the cystine stones, like I said, those are more rare. They can occur in both men and women. And typically these people have a genetic predisposition to these type of stones. We've talked a little bit about this throughout the slides here, but so risk factors for kidney stones includes family history of stones, people that have maybe a low fluid intake, people that are prone to gout, and then people that have had a previous bariatric surgery. They tend to excrete higher levels of calcium oxalate, so that's why they're a little bit more prone to those type of kidney stones. Again, with the pictures here, hopefully this will kind of solidify in your mind a little bit, but these are just common signs and symptoms of people that have a kidney stone. So a lot of the times the pain is sharp, it's sudden, it's severe, depending on if the stone is moving within the kidney or within the GU tract, the pain may be intermittent. A lot of the time it'll radiate into a flank area. A lot of these people will be nauseous, they might be vomiting, and then, to diagnose this, like we've talked about, you want to get some lab work, so urinalysis. A lot of the times we will do a renal CT or a renal ultrasound. And then you also want to make sure that you are straining the urine, because if they do end up passing the stone on their own, we want to make sure what type of stone, or we want to make sure we know what type of stone it is. This is a renal CT scan, and I like this one because it has everything labeled for you. Do not get down on yourself if you have a hard time reading these, because this is something that I was not taught in school, and I would say even I would say ultrasounds I kind of struggle with still. CT scans, over the last 3-4 years that I've been working at the hospital, I have gotten a lot better at reading what I need to read, just because I see them a lot. But don't be concerned if you don't know how to read these right away, because this is something that will come with practice. And if it's something that you do struggle with and it bothers you, then I would suggest getting a beginner's radiology book, and I have one that I can bring to class as well. But just something so that you are looking at these on a daily basis. It will help you understand better what you're looking at. But if you look over there at the left kidney, there is a large stone there, and typically they will show up white there on the CT scan. So what is the treatment for kidney stones? So a lot of the times, because these people end up having a lot of pain, I would say the majority of them end up in the hospital, probably on an OBS unit, just because they want some pain relief. But what we end up having them do is we want them to strain all their urine. We will end up doing a renal ultrasound or a CT scan to determine the size and the location of it. We'll do a urinalysis because we want to make sure that now we don't have a UTI as well if there's a suspicion for an obstruction. And then if they're unable to pass the stone, or if we're noticing that there is an AKI or an acute renal failure occurring, then we can involve urology. If they're in the hospital, we automatically refer to urology. If it's in the outpatient world, if you have a patient that really doesn't seem too uncomfortable, and they're able to encourage, or they're able to or you're encouraging their fluids and they're able to follow that and they're doing okay and they end up passing it, they may not necessarily need a urology referral for that. However, if you're noticing that it's reoccurring with them, I would definitely refer them to a urology so they can be monitored more closely and we can maybe try to prevent. Now, if you have a patient that comes into the outpatient setting and they have a high fever, or maybe they have extreme pain and they can barely walk, or if you're seeing lab work changes, then they need to be sent to the ER and treated. I also included a picture over here too. These are some foods to avoid And this is more so catering to the calcium oxalate type kidney stones. However, this can it can also just be an overall good diet to follow for people. But those are some of the foods that they can have, and then some of the foods that they can avoid. So patient education is key, especially if they have recurrent kidney stones.